Hello, everyone. This is Professor Osorio. I have a deep passion for quality improvement. It's incredibly rewarding, especially for those of us with a math or science focused mindset, to see outcomes that are measurable and impactful. Additionally, patient safety is at the heart of what we as nurses strive for in our daily practice. So, welcome to this brief lecture on quality improvement and patient safety. The Institute of Medicine cited six aims for guiding quality improvement in the nation's healthcare system. These aims include safe, timely, effective, equitable, patient centered, or STEEP. Safe is avoiding harm to patients from the care that is intended to help them. Now, timely is reducing waits and harmful delays for both those who receive and give care. Effective is providing services based on scientific knowledge to those who could benefit. And efficient is avoiding waste, including waste of equipment, supplies, ideas, and energy. Equitable is providing care that does not vary in quality because of personal characteristics such as gender, ethnicity, geographic location, and socioeconomic status. And patient-centered is providing care that is respectful of and responsive to individual patient preferences, needs, and values. The Institute of Medicine outlines 10 key principles for improving healthcare quality. These are continuous healing relationships. The care should focus on consistent and ongoing support. Two, patient-centered customization is when you tailor care to align with individual patient needs and values. Three is patient control. Empower your patients to be the primary decision makers in their care. Four is shared knowledge. Try to encourage open sharing of knowledge and free flow of information among all parties involved. Five is the evidence-based decision making. You want to base clinical decisions on the best available evidence. Six is system safety. You want to ensure safety is integrated into every aspect of the healthcare system. And seven is transparency. You want to foster an environment of openness and honesty in healthcare practices. Eight is anticipating needs. As a nurse or as a healthcare team member, you want to be proactive in addressing patients' needs before they arise. Nine is waste reduction. We need to continuously work to minimize inefficiencies and eliminate waste. And 10 is clinical cooperation, which is when we try to prioritize collaboration among healthcare professionals to enhance patient care. We all have the same goal, so we should be working together. The cornerstones of quality management include one, being quality, which is defined by the customer, emphasizing that customer expectations set the standard for quality in healthcare. Two is scientific approaches, promoting the idea that organizations should support all employees in developing knowledge and skills in the science of quality improvement or QI. The third one is that it reflects the belief in teamwork, where every member in the organization works together to serve the customer effectively. Let's discuss the role of regulatory and accreditation agencies in driving quality improvement in healthcare. Agencies such as the Centers for Medicare and Medicaid Services, or CMS, set quality standards, and require quality management as part of their conditions of participation. State licensing authorities also mandate quality management activities, emphasizing the importance of meeting established quality standards. Hi, dear water bottles, Jayco's here. Just kidding, but I'm sure you've heard that before. So, healthcare organizations often seek accreditation from the Joint Commission to show that they meet high standards in quality and safety. The Joint Commission is the predominant accrediting body, but there's also other agencies such as DMV. But TJC was one of the first agencies to integrate quality improvement principles as an accreditation requirement for hospitals. Accredited hospitals are required to collect standardized data known as the National Hospital Quality Measures, which is publicly accessible on the Joint Commission's website. It's listed on this slide. The National Hospital Quality Measures are standardized benchmarks that hospitals follow to ensure the delivery of high quality patient care. These measures focus on key aspects of healthcare, including patient safety, effectiveness, patient centeredness, and efficiency. They are critical for public reporting and performance improvement within hospitals. The mandatory measures specifically address areas such as acute myocardial infarction, heart failure, pneumonia, perinatal care, surgical care improvement projects, because by adhering to these measures, hospitals aim to maintain a consistent quality of care and improve outcomes for patients in these critical health areas. Take a minute to pause the video and answer this on your own, but the correct answer is C. The Joint Commission initiated the Performance Measurement and Improvement Initiative, known as the National Hospital Quality Measures, which is intended to support organizations in their quality improvement efforts as well as supplement their accreditation process. Now, A is incorrect because Pareto charts are bar graphs with the height of bars reflecting the frequency with which events occur or the effect events have on a process problem and are used in analyzing quality improvement initiatives but not required as part of the Joint Commission accreditation process. B is incorrect because never events were initiated by the Centers for Medicare and Medicaid and are serious adverse events during an inpatient stay that should never occur or are reasonably preventable through adherence to evidence-based guidelines. D is incorrect because the PDSA cycle is one type of quality improvement model and not specified as required by the Joint Commission. The foundation for quality monitoring and evaluation involves measurable aspects of care that indicate how well clinical procedures are performed, such as administering the correct IV solution at the prescribed rate. These measures serve to assess clinical care and highlight areas where quality improvements are needed and help set the goals for quality improvement initiatives. Process improvement strategies or models involve methodologies like Lean, Six Sigma, and failure mode and effective analysis or FMEA to enhance key work processes. Now, these strategies include identifying the workflow to pinpoint areas needing improvement, focusing on specific parts of the process that will yield the most benefit, and setting measurable goals to guide the improvement process, gathering information and using it to track progress, understanding data outcomes to make informed decision, taking steps to improve the process and assessing their impact. So as a previous nursing director, I frequently utilize Lean Six Sigma define, measure, analyze, improve, and control, or DMAIC approach to minimize errors. inefficiencies, to minimize errors, inefficiencies, and process variability, especially when addressing fiscal and staffing challenges. The upcoming slides will cover various process improvement tools, which are especially useful for monitoring quality improvement initiatives aimed at reducing patient falls, CLABSI, CAUTI, medication errors, hospital readmissions, etc. You name it, we can improve it. Unless, of course, your organization have perfected the process, such as in a lot of airline industry processes, but not so much in healthcare. Hospitals and outpatient facilities generally report on these metrics during monthly or quarterly quality improvement meetings. When quality measures are at risk or show sudden increase, like an unexpected rise in patient falls, these improvement efforts are reviewed more frequently, often on a weekly basis, until the situation stabilizes and the implemented processes demonstrate effectiveness eventually. A flowchart is a valuable tool in process improvement because it visually maps out each step in a process, allowing teams to identify inefficiencies, redundancies, and potential problem areas. By providing a clear overview, a flowchart helps simplify complex processes by breaking down complicated processes into manageable steps, making them easier to understand and analyze. It also helps identify bottlenecks by highlighting where delays or problems may occur, guiding where changes or improvements are needed. It enhances communication by offering a universal visual reference that improves communication among team members and stakeholders, ensuring everyone has a shared understanding of the process. Flowcharts also standardize processes by helping ensure consistency is how tasks by I'm sorry, by helping ensure consistency in how tasks are completed, promoting standard operating procedures across teams. Flowcharts also facilitate training by serving as an effective tool for onboarding and training, providing a step-by-step guide to new employees. Overall, flowcharts are essential for visualizing, analyzing, and improving processes to enhance quality and efficiency, especially in healthcare settings. A Pareto chart is a valuable tool in healthcare process improvement as it helps identify the most significant factors contributing to a particular problem. By visualizing data, a Pareto chart prioritizes the issues that, when addressed, can have the greatest impact on quality and efficiency. So here are the key benefits of using a Pareto chart in healthcare. It focuses on the vital few. So by following the 80-20 rule, indicating that roughly 80% of problems are often due to 20% of causes. So in healthcare, this allows staff to focus on the most impactful issues, such as the primary causes of medication errors or patient falls, thus optimizing resource allocation. Pareto chart also fosters data-driven decision-making. By providing a visual representation of data, these Pareto charts facilitate evidence-based decisions, and it highlights which problem needs attention first, leading to more effective problem-solving strategies, right? Because once you can figure out what is causing your biggest error, then you can put most of your resources to address that. And then it would drive down your overall number of medication errors or falls or whatever it is that you're trying to improve on. Another thing that Pareto charts could be good for is that they can be used to monitor changes over time. They can show how process improvements like interventions to reducing CLABSI or CAUTI rates impact outcomes, enabling continuous quality improvement. So once things have slowed down and stabilized, we can use Pareto charts just to very quickly monitor that it's not trending up again. Or if we want to show that things are improving, that it is trending down over time. So this is what I use the most when presenting in process improvement meetings because it helps shareholders understand the key areas requiring improvement and fosters a collaborative approach to problem solving. Overall, Pareto charts streamline efforts towards the most impactful solutions, leading to a better patient outcomes and more efficient healthcare processes. A cause and effect diagram, also known as a fishbone or Ishikawa diagram, is highly beneficial in healthcare process improvement. It helps healthcare teams identify, organize, and visualize potential causes of a specific problem, such as medication errors, patient falls, or hospital-acquired infections. By systematically breaking down complex issues into smaller, manageable factors like equipment? Is it processes or is it people? Is it the environment or is it a policy problem? The diagram makes it easier to pinpoint root causes, prioritize areas for intervention, and develop targeted solutions to enhance patient safety and care quality. I also love using run charts because run charts are valuable for tracking and understanding process performance, identifying trends, and guiding continuous quality improvement efforts in healthcare. Similar to a Pareto chart, it displays data points over a period of time, making it easier to identify trends, patterns, or shifts in a process. So this can help healthcare teams to understand whether changes are leading to improvement or not. Now, run charts track the performance of specific processes like patient fall rates or infection rates, allowing teams to see if processes are operating as expected. It helps identify variations within a process, distinguishing between normal fluctuations and special cause variations that may require intervention. By plotting data before and after changes, a run chart allows healthcare professionals to assess the impact of quality improvement interventions, showing whether changes lead to actual improvement. Run charts facilitate evidence-based decision-making by providing objective data that teams can use to decide whether further changes or interventions are necessary. I use run charts a lot to justify getting extra budget for staffing for the next fiscal year. So if I could demonstrate that by having a wound nurse started, say, in April of 2024, now that we are almost in November of 2024, since that wound nurse started, our wound numbers decreased by so much, and this is how much money we're saving because we no longer have to treat all these wounds and that patients don't have to stay here much longer because of hospital acquired wounds. Take a minute to answer this question by yourself, but the answer is C, because the Pareto chart is a graphic tool that helps break a big problem down into its parts and then identifies which parts are the most important or common. Now, A is incorrect because a cause and effect diagram lists all potential causes of a problem and it arranges it by categories. B is incorrect because a flowchart provides pictures of the sequence of steps in a process and does not identify the cause of the problem. D is also incorrect because a time plot graphs data points as they occur over time but does not identify the major cause or major causes of variation. Best practice refer to the use of standardized, evidence-based methods for providing care in a consistent and systematic way. Employees are trained to follow established procedures based on scientific research, rather than on relying on observational learning alone. So by doing this, we can help avoid random changes and ensure high quality outcomes. The Institute for Healthcare Improvement, or IHI, is a voluntary organization that supports healthcare leaders in improving quality. It has developed change concepts in areas like reducing patient delays, cesarean deliveries, and adverse drug events. The quality improvement model involves three fundamental questions. First, what are we trying to accomplish? Second, how will we know that a change is an improvement? Third, what changes can we make that will result in improvement? And this quality improvement models uses a plan, do, study, act, or PDSA cycle to implement and evaluate changes effectively. Here is a link to the cartoon of a process improvement video I made for a graduate school project in 2015. I just stated myself. It showcases the technology available at the time, so please reserve your judgments. But the project involved implementing a primary care clinic staffed by a nurse practitioner or staffed by nurse practitioners to reduce non-emergent visits to the emergency department. Although the video doesn't show it, a PDSA or a Plan to Study Act cycle was a key driver prior to the project's implementation. The Institute for Safe Medication Practices, or ISMP, is a nonprofit organization that serves as a educational resource for preventing medication errors. It provides expert independent reviews of reported errors and offers a confidential voluntary reporting system for healthcare professionals to share medication errors or hazardous conditions. ISMP also provides medication safety self-assessments to help professionals evaluate the safety practices within their work settings. More information can be found on their website at www.ismp.org. Programs initiated to improve patient safety include the Joint Commission Sentinel Event Standard, which requires healthcare organizations to perform root cause analysis to understand the factors behind adverse patient events. There's also the Joint Commission's National Patient Safety Goals, which outlines specific safety goals to enhance patient care. There's a reference in box 22-1 for the 2018 goals that was established. There's also the Centers of Medicare and Medicaid Services, Never Events. This identifies serious preventable and costly errors for which CMS will not reimburse additional hospitalization costs. The professional nurse and patient safety means improving patient safety requires collaboration among all healthcare providers to analyze critical events and learn from them. Nurses have the responsibility to prioritize patient safety through first monitoring and early recognition of adverse events, complications, and errors. Second, by initiating timely interventions by deploying appropriate care providers for rescue in critical situations. The Quality and Safety Education for Nurses project was established to help develop 6 core competencies for nursing students and practicing nurses. These competencies are patient-centered care, quality improvement, teamwork and collaboration, evidence-based practice, safety, and informatics. Focusing on continual improvement in these areas empowers nurses to enhance the quality and safety of healthcare systems. Nurses should enter practice equipped with the knowledge and skills to integrate quality improvement into their daily work. Quality improvement is not an isolated task, but an essential ongoing part of the professional nursing role. In my experience, focusing on quality measures has been highly beneficial. A mentor once shared a valuable phrase with me: inspect what you expect. If we aim for high standards in patient outcomes, such as preventing infections, falls, and other harm, we must actively incorporate quality measures into our practice. This approach holds us accountable to our profession and, most importantly, to the patients who trust us to provide the best care possible. I understand the immense pressure of balancing multiple priorities, especially when a patient's life is at stake. Most of my patients are critically ill, some barely holding on. Despite the challenges, my team of outstanding nurses and I work tirelessly to ensure that even the most complex patients, those on multiple vasopressors with a do not turn order, open chest on ECMO, CRRT, and right-sided Impella, do not develop CLABSI, CAUTI, or pressure injuries. We've seen too many success stories to not be strong advocates for quality assurance and process improvement. So I thank you for your time and attention. As usual, please do not hesitate to contact me for any questions, suggestions, or just for any comments that you may have. I hope you are having a great day. I'll see you in class.